You know, one of the things I learned is that lung age is kind of important when you do spirometry. Then congestive heart failure is the leading cause of deaths right now in diabetes, and most people with cardiovascular disease will be congestive heart failure. So we have some videos on that. And one of the things is hypertension, how to measure hypertension. And what I learned about hypertension is that the best blood pressure turns out to be less than 120 over 80 again. And should we achieve those targets? Well, that's a discussion for a different day. But basically, there's actually now data from the recent meta-analysis that was presented at the European Cardiology meeting that getting blood pressure down to 120 over 80 is a good thing. And how do we stay healthy during the pandemic? What we learned about that is that one of the things that Harvard has a wonderful study, it's about 80 years long, and the number one predictor, let me see if anybody can actually tell me the number one predictor of how long you're going to live. It was done through Harvard. It looked at, and so we'll get the first copy of the book here. So does anybody know what that is? Is it cholesterol? Is it triglycerides? Is it smoking? What's the number one predictor of living a long, healthy life? Does anybody know? What are people's guesses? Anybody? Silent.
HDL.
It's what?
HDL.
HDL. Okay, that's not a bad idea because HDL is a good predictor of risk. At one time, it was a target of therapy, and there was something called HDL Milano, where people actually infuse that into people's bloodstreams because in Milano, Italy, was a place of longevity. But unfortunately, that didn't work. So HDL cholesterol is no longer a target. It's a measurement of risk, but it's a good idea. Any other thoughts?
And again, please unmute yourself if you'd like. We'll take a look at the chat. It says MCR.
Oh, we got one here. We got the social context.
Yes.
Is that Natalie there?
That's right.
Who's Natalie? She got it right.
Social contact. Okay.
So basically, the number one predictor.
Sorry, I'm using my wife's phone. It's actually Ben from Hamilton. Yeah, social contact.
Yeah, Ben, very good, Ben. So one of your social contacts is Natalie, your wife. So basically, the number one predictor of longevity is the amount of good quality relationships that you have. And who would thought one of those softer risk factors would be far the most important. So one of the things what this pandemic has taught me is how do we, work together? How do we work together in a better way of things? So I'll get Phil at some point in time to bring you over a copy of 30 Days to Healthier You. So this is a book that I'm very proud of. It's a book that my team has put together. I can procrastinate. It took me only 25 years to write this book. I rewrote it about 20,000 times, it seems like. So I hope it's something that you find a little bit entertaining. It has everything from recipes to science to a sense of humor and hopefully some really good information from the science right now. Yeah, so number one predictor of longevity is good quality relationships. Well done. Next slide, please.
Sure. One moment.
And I want to give a book to everybody tonight. So if you have to say something, you get a book. And
you mentioned reduce it in the book, don't you?
Yeah, reduces is in the book. It's actually stories of vitamins. There's a story about my hero, my dad, and there's really good science about LDL cholesterol. And one of my favorite recipes is by someone called Rachel. Rachel has been one of my students for a number of years, and she actually made me a salmon meal that 4,000 milligrams of EPA in it. Turns out that Atlantic farm salmon has the richest sources of EPA. And I had a nice big meal of salmon that night, and I got the 4,000 milligrams of EPA in there. I also got DHA in there as well, but I was able to eat 4,000 milligrams of EPA. So we'll go to Michelle here. Michelle's 67. She's like most of us, overweight. Body mass index is 31. Her hemoglobin A1C is actually pretty reasonable. In fact, heart disease starts at a risk of a hemoglobin A1C above 5.5%. The higher that level is, the higher risk of vascular disease. And the mistake that we made for many years is that lowering blood sugar, an aggressive lowering of blood sugar only translates to reduction of heart attacks by about 12%. That's Gerstein's meta-analysis. meta-analysis that shows this, that so lowering blood pressure has a very small impact on heart disease. Predicts risk. It doubles risk easily, but it doesn't actually lower risk by lowering the blood sugar. And one of the things is every time you smoke, you lose about 10 minutes of life. Having a heart attack in the past, unfortunately, triples your mortality. Having a low HDL cholesterol increases your mortality, and having a triglyceride somewhere north of 1.5 increases risk in having low GFR. So, so this person is secondary prevention, and this person is on traditional medications of aspirin, atorvastatin, and valsartan. Does anybody have a comment about some of those medications? And we're going to come back to that case a little bit later. So LDL cholesterol is 1.3. It's below the so-called old target of 2.0. Is that the right target? What about an LDL cholesterol 0, for instance? And is that triglyceride of 1.9 a good thing or a bad thing, and HDL less than 0.9? We're going to spend some time thinking about that, and at the end of the discussion, I'll give you some answers at this point in time. So one of the things that aspirin, 81 milligrams a day, only lowers risk of vascular disease about 10 to 15%. So it's not a bad step, but it's not a great step as well. And aspirin increases the risk of bleeds, an absolute risk about 1% per year. And especially over the age of 70, the risk of bleeds goes up significantly even higher. So lots to think about. And does anybody have any thoughts about that at this stage, what we should be doing for this person? We're going to encourage smoking cessation, we're going to encourage weight reduction, and maybe a lower blood pressure. Are we going to get LDL lower? Are we going to deal with triglycerides? So much to think about. And how do you prioritize? Well, whatever the patient wants to do, I guess, is we encourage, but we have to help people make right decisions. Any comments from anybody just yet?
I don't see anything in the chat right now.
Perfect. Okay, we'll come back to that a little bit later.
Sure.
And the next case. So next case is a primary prevention trial, primary prevention patient who has hypertension and diabetes for 7 years. You can see the body mass index is on the high side, hemoglobin A1C is too high, LDL 2.2, HDL 1, triglycerides 2.2. So this person hasn't had a cardiovascular event. The person heard about the SGLT2 receptor antagonist, is on basically Forxiga and metformin, is on what I call the pissing in the wind dose of rosuvastatin, 10 milligrams a day, and on perindopril, 8 milligrams a day. So one of the things is that can we do better? Should we do better? Because many investors will say, you know, it's pretty close to 2. That's a reasonable starting point. And one of the things I learned is one of the best predictors of bad outcome in diabetes, because diabetes is unfortunately one of the best fertilizers for atherosclerosis, is duration of diabetes. So people have diabetes over 10 years, you're in trouble. People who have end organ damage of any sort, from proteinuria to changes of cardiovascular disease or to eye changes, are at higher risk. And one thing I've learned is that if you develop diabetes before the age of 50 years of age, and so this person develops type 2 diabetes by the age of 45, this person is at extremely high vascular risk long-term. Versus if you develop type 2 diabetes in your 70s, the risk is not as great. So the thing that worries me, if I ever see a patient who has type 2 diabetes before the age of 50, I worry a lot. And so I worry a lot about this patient. Do people have any comments just yet at all, or any thoughts from anybody? Not yet. Okay, we'll go on to the next.
Sure. And again, I'll just say to everyone that's joining, if you do have any comments, you can raise your hand. You can ask a question directly, and if not, we'll just keep moving forward. But I will moderate if you have. Here's one question by Adam El Kadi. Would the best course of action be to reduce the LDL in this case?
Yeah. I kind of like that idea. So I said, to me, is that there are 2 pathways in lipids. One is the LDL receptor pathway, that's the liver intestine. So getting LDL cholesterol. What I hope you walk away at the end of the discussion is that LDL cholesterol is a bad guy, and you don't need any LDL cholesterol. You're born with an LDL cholesterol of 0.7 to 1.4, and you basically mature quite well. LDL cholesterol it serves no really good healthy purpose other than to cause atherosclerosis. Every cell in your body can make its own cholesterol except for one. So here's the next thing for the next book over here. What cell in your body can't make its own cholesterol? So your liver can make cholesterol, your brain can make cholesterol, but what group of cells can't make their own cholesterol? Anybody know? Turns out it's red cells because they have no nuclei. So that's the only cell in your body that can't make its own cholesterol. Now, you need ApoB to transport fat-soluble vitamins, but you don't need LDL cholesterol. And basically, that will show you that lower is better. So in many individuals, I will try to erase LDL cholesterol, get it undetectable. The other issue too, of course, is this person has a triglyceride 2.2. Is that a good thing or a bad thing? Does anybody have an opinion on that? And triglyceride is a different pathway. I call it the lipoprotein lipase pathway. So this is a different pathway that's involved in energy production, free fatty acid metabolism, and that's something to think about. And that's a separate pathway distinct from LDL cholesterol. So I want to think about two pathways. So getting LDL cholesterol very low is important. And what should we do about triglycerides? And that's something we're going to spend a little bit of time talking about today. Many individuals will just stay at that level. So getting LDL cholesterol low is a good idea. And let's actually explore that a little bit more. Next slide, please. So one of the things is I can talk really fast. So you need to don't forget to pause. Now, when I started my practice over 30 years ago, and by the way, I'm 61. I plan to retire on my 100th birthday party, and you're all invited. I've learned a lot, and there's a lot more to learn, and I want to share whatever I have. So right now is that the leading cause of deaths with cardiovascular disease. Right now, cancer and heart disease are fighting it out. And I'm pleased in Canada, probably cancer is the #1 killing disease process, followed by heart disease. So right now, 1 in 12 Canadians have cardiovascular disease. And traditionally, once you had heart disease, you were likely to die from heart disease. But because of the therapies we now put into place, people are less likely to die from heart disease. You'll die other disease processes. And congestive heart failure is now the leading cause of death right now in people with diabetes and cardiovascular disease. So you can see that 12 deaths take place every hour. And if you have cardiovascular disease, your likelihood of dying from it is now 3 times higher. So the best marker for heart disease is having a previous event. And second are the risk factors. Next slide, please. So we've made great inroads. And one of the things that I learned is that Framingham, I think, started around 1948. So we've over 70 years of good data on how to measure cholesterol, what to do, especially about LDL cholesterol. I'm not sure people remember where they were in 1994 when the 4S trial was presented. So the 4S trial was a landmark trial. These were people with a baseline LDL cholesterol 3.02, and simvastatin 20 to 40 milligrams a day, an older generation statin, showed for the first time a reduction in total mortality by the treatment of cholesterol. Prior to that, and I think Philip remember back then, he's part of the old club as well, is that we use things like cholestyramine, and we use things like gemfibrozole, niacin were very popular drugs back then. And they were very difficult drugs to use, and lovastatin came into place, and simvastatin came into place, and that actually showed an absolute mortality reduction by about 30% or so. So key landmark trial, but LDLs were at 3. Then you can see these series of trials with lower and lower cholesterol of 2.5, 2.5. And then we have the primary prevention trials that showed benefit as well. So the meta-analysis of statin therapy is well over 200,000 patients, and it shows for every 1 millimole reduction of LDL cholesterol, vascular events by about 20%. Lower tended to always be better. But we in Canada and many countries got that magic number of LDL 2.0 in very high-risk patients. Next slide, please. what we have here, a very interesting trial, is that should we use ezetimibe or not? Very interesting. So ezetimide's been around for a long time. It has basically two landmark trials. This is called the Improve It trial. So it took patients on simvastatin, an older generation statin, and the baseline LDL cholesterol was 1.8, and you got 10 milligrams of ezetimibe, LDL cholesterol fell by a small degree. But the very interesting thing part about this trial, it took about 7 years to show benefit, but 40% of individuals by the end of the trial had stopped ezetimibe. People stopped their therapies. So just imagine what would happen if you kept it going. So I think of statins being like Wayne Gretzky, and I think of ezetimibe being Marty McSorley, the protector of statin therapy. So right now, because ezetimibe and statins are generic, they cost less than 25 cents today, and they show a linear relationship that lower is better. So one of the messages is that lower is better, and longer is better too as well. Next slide, please. We then came to the PCSK9 drugs. Now the PCSK9 drugs are landmark trials. There's two big ones, the Fourier trial, the Odyssey trial, and this starts with an LDL cholesterol baseline at 2.4 on top of statin therapy, a little bit of ezetimibe, getting LDL cholesterol to an average of 0.8 millimoles. And it showed an additional reduction of cardiovascular events by about 20% over a period of 2 to 3 years. The numbers needed to treat are not bad. But again, this is basically a very aggressive lowering of cholesterol, and lower became better. And one of the things I hope to see is that if you got LDL cholesterol down to 0, would atherosclerosis go away? And the answer, it doesn't. There's a lot of persistent risk still behind it. You get another chunk of 20% by getting LDL cholesterol further, but there's still a lot of residual left over. Next slide, please. And the Odyssey outcome trial showed the same thing. Now, Odyssey was afraid to get to too low. So if your LDL cholesterol got to low value, you were backtracked on therapy. So LDL went from 2.6 to 1.4. It showed another 15% reduction of cardiovascular events, lots of residual risk. So, and all these trials have shown that lower is better and longer is better. We know that from genetic studies. So if you're PCSK9 deficient, so that means your cholesterol is lower from births, those people live longer, and a 10% reduction of cholesterol over a lifetime translates to a 50% reduction in cardiovascular events. So a 10% reduction in LDL cholesterol over a lifetime will translate to a 50% lifetime risk of vascular disease. We also know that people who have familial hypercholesterolemia, a genetic disorder where LDL cholesterol in adults are over 3, the lifetime risk of a vascular event is 80%, with 50% of people having a vascular event by the age of 50. So the story about LDL cholesterol is clearly that lower is better and longer is better. So remember, all your cells in your body can make its own cholesterol except for mature red cells. So there's been no real concerns about safety. The only thing that comes and goes from time to time is that hemorrhagic stroke. And I tend to believe that if you suck out lipids out of vessels, you probably make yourself more prone to hemorrhagic stroke. But hemorrhagic stroke, if blood pressure is well treated, is not a major issue for most of us. And we see very little of that at this point in time. So this is exciting times for LDL cholesterol. And basically, as was pointed out before, is that being on the highest dose of statin therapy with 10 milligrams of ezetimibe is sort of the gold standard. Sure, it'd be nice to add to PCSK9 drug, but these drugs are awfully expensive. The retail price is about $7,000 a year in Canada. There are some discounting available from different ways about that. We can talk about that if you care to look, if you want to later on. But so this clearly shows that a very mature field with LDL reduction, but also shows that despite a very aggressive LDL cholesterol, there are still other things to think about. And one of them is the triglyceride pathway we'll talk about. We'll talk about other avenues in this area. So as you can see that triglycerides, so for sure, triglycerides, the high triglycerides level above 1.5 identify increased risk. And we'll come back to whether or not you think that we should lower triglycerides to decrease cardiovascular events. I will say that triglycerides is very amenable to lifestyle changes. We talked about anything that's alcohol. If you have a triglyceride greater than 5, your risk of pancreatitis when it shoots up greater than 10. So if you have a triglyceride problem, you want to lower your triglycerides to prevent pancreatitis. And what I'm going to do is that during this COVID pandemic, I spent a lot of time trying to work hard at my weight. So my ideal weight, I decided was 165. I have body composition on myself. And so I achieved that goal right now. And one of the videos you can look at on our website is I've used a keto diet rich in fish as part of that, but I also believe very much in plant-based eating. We know that oxidative stress, diabetes, hypertension, what you see also is LP little a. So 20 to 25% of us have this abnormal particle. It's basically a derivative or variant of LDL cholesterol. It's probably not, it's measured as LDL cholesterol, but it's probably not LDL cholesterol. If you can just keep that slide there, wonderful. It's very thrombogenic, it oxidizes. You need to measure that once in most people's lifetime, and it basically gives you a higher risk. So if you ever look at our video on genetics of atherosclerosis, we'll talk a little bit about that as well. And one of the things is that I have something called familiar combined hyperlipidemia, which is a genetic abnormality was associated with triglycerides. I also have a second hit, high LP little a. So I try to keep my LDL cholesterol as low as possible, as well as looking at and I manage my triglycerides at this point in time with lifestyle changes. But we can talk about that as well, because we know that the higher triglycerides is a marker of risk. And we'll show you some things where triglyceride becomes a target of therapy if you consider that. So we know that thrombosis, endothelial dysfunction, inflammation is a very interesting area at this point in time. CRP is something that you can measure, and CRP over 2 is a marker for increased risk. It's seen in people that are overweight, and many people that are overweight will have this central adiposity, a higher CRP, but it's also found in high triglycerides, in diabetics, in people with connective tissue disorders. So we know that rheumatoid arthritis, psoriatic arthritis all cause inflammation. And we now have multiple trials that lowering inflammation, lower CRP with either colchicine or other agents can decrease atherosclerosis as well. And probably also fish oils, if you use the right preparation, can also lower that too as well. And you know, the stability of plaques and oxidative stress. And in the past, we used to think that vitamins were good antioxidants. They are good antioxidants, but they're antioxidants only in the bloodstream. They're not antioxidants at the tissue level. Or we can actually get to tissue levels right now. And it turns out that EPA is probably an antioxidant. It probably affects plaque formation in the tissue itself. And we'll show you some data to help support that as well. Next slide, please. So lots of excitement, a lot of things. So if we just think of LDL cholesterol, so lower is better and longer is better. But what about triglycerides and other markers? Let's go look at that. And the next slide, please. And so this is a trial that basically shows that triglycerides is associated with heart disease, and lowering triglycerides may be a good thing. Now, it's very interesting that in trials with a triglyceride somewhere over 1.5 to 2.0 is very much associated with increased cardiovascular risk. And that we have trials that show that lowering triglycerides, if you treat high triglycerides and low HDL cholesterol, probably are protective. But there's a dispute of that, and we'll come back to that in a few minutes. Next slide, please. And so this actually shows for the Copenhagen City Heart Study. This is a trial of it's observational data, just under 100,000 patients. So, you know, about 98,000 patients plus. And it shows that non-fasting triglyceride is a marker for heart attacks, strokes, all-cause mortality, ischemic stroke. And you can see that somewhere around 1.5 or greater, the risk of vascular events goes up. And it goes up, the higher triglyceride, the higher your risk. So that's been known for forever. Next slide, please. And this just shows it more elegantly here, and another way of looking at it. So you can see that. So one of the things that, should I have a target of LDL or triglyceride less than 1, for instance, and an LDL cholesterol less than 1? Just sort of think about this as we go on here. So we know that once we treat cholesterol, LDL cholesterol, that the triglycerides that are not treated increases your risk. Next slide, please. And we have this a big problem in Ontario and other parts of Canada as well. And so what about the fibrate story? Because when we first started, we're saying, we got to treat HDL and triglycerides. And you can see that most of the newer generation trials, such as Accord and Field, Accord used a combination of fenofibrates and simvastatin. The Field trial used Lipidil Easy on top of that. And overall, the trials were negative. However, in subgroups of all lipid trials, a triglyceride greater than 2 and an HDL less than 0.9 is associated with benefit to fibrate therapy. So we're going to have so to me, the story about fibrates, there will be another trial coming out in the next few years with another newer fibrate that affects PPARs and gamma PARs and other areas of the field. And we'll have a better look at that right now. So my belief, and it's not believed by everybody at this point in time, is that triglycerides that are full of remnant particles are atherogenic. And I'll show you a slide. And one of the things that people ask, is it more important to measure fasting or non-fasting triglycerides? So to me, if you have I think non-fasting is probably the best for most of us. And if you have a triglyceride level greater than 5.0, then by convention, we tend to measure that in the fasting state. So to me, I don't get too different between fasting triglycerides or non-fasting at levels less than 5 or so. The postprandial rise in triglycerides. So most of the fats we tend to eat isn't your body will make something called chylomicrons and VLDLs, and these are particles that are rich in triglycerides. So from a practical point of view, triglycerides less than 5, non-fasting is very, very reasonable to have. If your triglycerides over 5, then you should look at this. Now, niacin is a very interesting drug. Way back when, the Coronary Drug Project showed that niacin made you live longer, but you had to use huge doses of niacin, 4,000 milligrams plus. Now, I don't know if any of you tried niacin. I took a couple thousand milligrams when I just became the director of the lipid clinic. I went water skiing. I had too much to drink, and I had the most amazing flush that you ever see. It would be scary if you didn't know what was happening. So niacin is a very hard drug to use, and it's no longer utilized because in more recent data, on top of statin therapy, it adds very little. Then the story of antioxidants and vitamins have come into play. And so there was initially something called GC prevention that showed a benefit. But overall, 1,000 milligrams of combinations of EPA and DHA are negative for vascular disease. So this brings up the mother and the mother-in-law rule. If it's someone you care for and you love, you will not give them DHA and EPA at this point in time. I think President Trump should try this cocktail and just see what he or she thinks about this. But I also think is that we learned a lot, and we're going to talk about pure EPA in a second, showing reduction of cardiovascular events. Now,
Dr. Kernew, sorry to interject. I have a couple of questions, which actually is quite relevant. So you did go over non-fasting and fasting triglycerides, but there's a question just in general, what is more accurate when you're looking at fasting lipids or non-fasting?
So traditionally we measure lipids fasting, but I would argue we don't spend most of the time in the fasting state. So by convention we measure it by fasting, but probably what is more accurate is the postprandial rise, the non-fasting lipids, which is probably a more accurate reflection of triglyceride-rich particles. But between fasting and non-fasting, if your triglycerides are 3 to 4 or less, it doesn't change that dramatically, unless you go on an alcohol binge or something along those lines there. So, not fasting is a convention, but non-fasting is probably a more accurate reflection of the burden of triglyceride particles in your bloodstream. Excellent. So, go ahead, yeah.
And then a follow-up question, which is exactly ask the expert, what is the role of Q risk in predicting 10-year risk, heart disease, or stroke? Is it worth calculating still?
Was that the Framingham risk? I'm sorry.
I'm not sure. It says Q risk. I
Q.
don't know if
I don't know
I'm
what
not
Q.
recalling that either, but might be. I
So we
don't
talk.
know.
Well, there's different risk scores. There's the
Q
score.
risk is in England. Sorry, it's by
Okay.
Adir. And by all means, if you want to unmute, you can ask the question directly as well for further clarification. But Q risk is used in England.
Okay. There are different scoring systems. So Framingham is a little outdated in North America. There's been different versions of that. We tend to use a variant of Framingham. But one of the things is I'm starting moving to a lifetime risk of vascular disease. So one of the things I've learned is a 10-year risk is a good predictor. There's a score. There's different risk models all over the world, and so you can use it. You can use that, but what's come of age is something called polygenic scores, where interactions among multiple genes. It's not ready for prime time right now. So as of today, is that it's certainly important to calculate 10-year risk of heart disease, and the highest risk patients are those that have vascular disease or enrichment of risk factors, such as vascular disease in multiple territories. And if you save that till the end, I'll show you what the European guidelines say about that. 'Cause I think the European guidelines are the best guidelines that are currently available. They've been updated recently, and the Canadian guidelines are going to come out sometime this fall. We'll see what Canadians have to say about this. But so I'm thinking more of a lifetime risk of people, and I'm going to come back to that question a little bit later when we look at the European guidelines.
That's excellent. And just out of interest of time, there's a lot of questions obviously on this and this component. So Dr. Kearney, I think you really hit the nail here with the guidelines as well. But one final question before we start moving on. It's about 7:40, so I hope everyone is enjoying this and they're okay with staying on a little bit longer. But from Reza, he's asking, he or she, sorry, is asking basically, should we check lipids for healthy younger than 50 years old patients or not?
Yeah. So the Americans have decided to screen everybody. Canada has a more selective approach, but I think one of the diseases called familial hypercholesterolemia is a genetic abnormality present between 1 in 100 to 1 in 200 in Canada. In Quebec, it's 1 in 125. In Ontario, it's 1 in 200. So you suspect someone has early heart disease before the age of 55, someone who's a smoker, diabetic, hypertensive, very positive family history. I don't think it's unreasonable to start screening uh, earlier in life. So I think knowing what your cholesterol somewhere on the age of 20 to 40 for most people. If everybody lives in your family to 100 years of age and you're healthy, you can say that maybe not my priority, but the average individual in North American is at risk. We're gaining weight at a very alarming way. We have glucose intolerance in many people. So I think knowing where you stand is always important. So I think somewhere around the age of 20, unless you have a genetic abnormality. The youngest heart attack that's been described was a heart attack in a young boy that died at the age of 2 years of age. He died of a massive heart attack. He had very severe coronary atherosclerosis. He was homozygous for familial hypercholesterolemia. He had a cholesterol of 25, and that's a very specific genetic disorder. There's probably about 30 people to 50 people in Canada with specific genetic abnormality. So those were people with very positive family history. So if you have heart disease before the age of 40, you should screen. But for the average individual, somewhere in the age of 20 to 40 is not unreasonable to screen. And of course, based on risk factors. So what I want to say about vitamins at this point in time is that if you use combinations of EPA and DHA less than 1,000 milligrams a day, uh, it doesn't prevent heart disease. There's a very interesting trial called the Strengths trial that was just stopped earlier this year. It used 4,000 milligrams of both DHA and EPA, pharmaceutical grade. It was an AstraZeneca um, compound, and that was stopped because of futility. So that's going to be presented in November at the American Heart Association meeting. So we're going to learn a lot about the combination of DHA and EPA in a little while. Trilogy is another pure EPA compound that's under going further testing at this point in time. So let's explore what we do know about EPA and DHA. Next slide, please.
Perfect. And just there are some questions, but we'll entertain them at the end.
Go ahead.
Okay. Well, it's a fairly simple question in the sense of the question. Does high triglyceride risk differ in type 1 as opposed to type 2 diabetes?
Yeah. So we have a lot more data with type 2 diabetes. And I think of type 1 diabetes as something being totally different than type 2 diabetes. Type 2 diabetes is a disease of insulin resistance and initially an overproduction of insulin. And type 1 diabetes is a disease of deficiency of insulin. So they share blood sugar, they're different diseases. So uh, what I will say is I'm going to concentrate more on type 2 diabetes. I sort of think of the duration of diabetes. So if you have type 1 diabetes, you never develop proteinuria and organ damage after 20 or 30 years, you're probably going to escape that. But the reality is that most people with type 1 diabetes will develop end organ damage. So you need to follow those patients. And those patients you can actually follow with things like proteinuria initially to guide therapy. Where type 2 diabetes is a vascular mess. You have remnant triglycerides, they're thrombogenic. Those patients, it's more than just lipids. And the problem with type 2 diabetes is that we concentrate so much on blood sugar. And I will say that we should concentrate on other things such as triglycerides, losing weight. And if you're at type 2 diabetes, if you lose 20 to 30 pounds, you can put type 2 diabetes in remission between 50 to 70% of the time. So type 2 diabetes cannot be cured. It can be put into remission at this stage. Where type 1 diabetes is destruction of beta cells, usually through antibody production, that can be treated with islet cell transplant, and that's a different disease altogether. So I think they're much differently. They certainly have vascular disease in that category, but the type 2 diabetes are the ones that have most of the vascular disease I tend to see. As an adult cardiologist, I don't see that much type 1 diabetes. Next slide, please.
Thank you, Dr. Kearney. Learning a lot. I hope everyone else is.
So we know that most compounds are a mixture of EPA. So fish oil, omega-3s, are a combination of three products: EPA, DHA, and that's the fish fats. But there's also omega-3s derived from vegetables. So the combinations, this is a meta-analysis of combination of EPA and DHA. You can see this meta-analysis really doesn't show much benefit. Now, most of these patients were treated around 1,000 milligrams or less of combinations EPA, DHA. And so that combination turns out DHA is better for the brain, EPA is better for the heart, does not show a vascular effect. In about 2 months from now, we're going to have a whole wealth of information when the strength trial gets presented. So that will be 4,000 milligrams of EPA, DHA pharmaceutical grade. And that trial again was stopped because of neutrality. Or basically because of lack of benefit, and we'll take a look at that. It wasn't harmful, but wasn't positive. But we'll know a little bit more. So right now I can say that EPA and DHA in different combinations have not shown to be vascular protective in a meaningful way. Next slide, please. And this comes back to some of our webinars. So one of the things that, if you look at the bottom, is exercise. Exercise is so important. It's really important. For every 1 MET increase in activity, vascular events fall by about 10% or so. How to deal better with COVID and how to deal with patients during this pandemic. We can share some thoughts at the end, but also to the genetics of atherosclerosis is actually very important to look at that. And so you can see that many times I talk too long. That genetic video was over 2 hours long. So if you want to understand about genetics, it's written for smart people, smart patients who want to explore this. So I'm really proud of the team for putting that together. So I'll just leave that for you to peruse at any point in time. If you go to YouTube and put my name in there, we'll take you to our YouTube channel. We have over 100 videos to look at. Next slide, please. That's a younger version of me there. The next thing is that the Gillis trial. This is actually a landmark paper that's quite old. And let's actually look at the design of Gillis. It was done in Japan. And basically, this is a trial of just under 20,000 individuals. So 18,000 patients, Japanese, mostly females, mostly primary prevention. It was a mixture of primary and secondary prevention. And they actually got pure EPA, one of the fish oils, one component of fish oils, about 1.8 grams a day versus matching placebo. This was on top of statin therapy. Let's look at the next slide. So it went on for about 5 years. So a huge trial. The baseline was basically Japanese aren't as big as North Americans, body mass index of 25. And the vast majority were primary prevention patients. Only about 20 to 30% had vascular events. Most of it was primary prevention. And in Japan, they smoked too much, or at least they did. And most of them, and that 70% were women. And you look at the baseline cholesterol, 7.1, LDL 4.69, HDL 1.52, triglycerides were 1.73. So they were on average elevated, but they had a lower triglycerides in many of the trials. Next slide, please. And they were all given, and they were all well treated for their blood pressure. And they used basically pravastatin, simvastatin, older generation statins. There wasn't that much background therapy because most of it was primary prevention. And the Japanese, we a much lower dose of statins compared to North Americans. So for the same dose of a statin therapy, Japanese of background will have 3 times the serum level compared to a white Caucasian like myself. Next slide, please. And what the trial did show was a reduction of cardiovascular events. So this is actually given, everybody got statin therapy, and then you got EPA 1.8 grams a day, we're matching placebo in that circumstance. And what it did show was a 20% reduction of cardiovascular events. So we used statin therapy and they got 1.8 grams of pure EPA, pharmaceutical grade EPA. And that's important is that in Japan, they consume 5 times the fish compared to North Americans. And so the level of EPA approaches that in the reduced trial. And that actually showed a reduction of cardiovascular events by 20%. A lot of it primary prevention, a lot of it in women. And it also showed that people whose triglycerides were above the mean of 1.5 had a much greater benefit compared to people that have a lower triglyceride. So it showed that regardless of triglycerides, it showed a vascular protective effect on top of statin therapy. So that's a trial of just under 20,000 patients that has been forgotten. It was published in 2007. So put that in your brain and put that aside for now. Let's go to the next slide. So this is a big landmark trial. So to summarize a few things, that LDL cholesterol is important. Next slide over here. However, triglyceride is a marker of risk, and if you pick the right triglyceride particles, it can be a marker of potential therapy because those are called remnant particles. And we'll take a look about that. So the JALIS trial showed that you showed benefit of using EPA, getting to a very high level, showed reduction in cardiovascular events. It showed that regardless of triglycerides of benefit, those with the highest triglycerides, and the high triglycerides are a marker of risk. And that we know that the conventional omega-3s that you buy at Costco's or Shoppers Drug Mart do not prevent cardiovascular events. And that pure EPA decreases cardiovascular events. And that's sort of a compound that was studied in the REDUCE-IT trial. We'll come to in a few minutes from now. Next slide, please. So one big landmark trial that suggested that pure EPA is good, and that we know that combination DHA and EPA are bad. So EPA is one of the components of fish oil. Fish is made predominantly of EPA and DHA. IPA is basically a more stable form of EPA. So IPA is more stabilized, doesn't oxidize to the same degree, and it gets converted to EPA, the active ingredient. And most preparations of fish oils have combinations DHA and EPA. And it turns out is that it's the EPA component that is vascular protective. And most of the commercial fish oils that you get are either rancid, they're full of contaminants potentially, and full of saturated fats. And we'll show that a little bit later. So what you're going to see is that omega-3s, so omega-3s are rich in EPA and DHA, and they have anti-inflammatory properties. So ALA is the vegetable form of fish oils. They get converted to a very weak degree, 2% into EPA and DHA, but these are found things like canola oil and flax, and they've been shown to variable degree they may have some cardiovascular protective effects. Where omega-6s are a different fat altogether, and they're more of the vegetable fats, and they are more prone to causing atherosclerosis. We talk about a ratio omega-6s to omega-3s. So it turns out that EPA has anti-inflammatory, anti-thrombotic effects, and other properties that are cardiovascular protective, and that DHA may be doing the opposite of what we want it to do. So let's go to the next slide, please. So there's a chemical slide about that there. And again, is that fish oil is a combination of EPA and DHA, but a purified version of EPA, IPE, which is more stable, coming from fish, krill, is a very is a more stabilized form. And if it's done in in a very proper manner, it doesn't oxidize, it's not rancid to the same degree, and it has a prolonged shelf half-life. How long can the EPA capsules be kept for? How long are they good for? Do you know?
So, apart from the product monograph, about 2 to 3 years. So it does have a longer shelf life than you would with over-the-counter formulations, which are prone to oxidation, and that's why you'll see the color change and whatnot. But it's a good chance to ask a question. So there's one by, again, sorry, I forgot the name. Was it Ben or Bill? I can't remember, but it's Natalie's abductive phone, or John, sorry. What are your thoughts of the Japanese study using the weaker statins versus the atorvastatin or rosuvastatins of the world? Would that artificially augment the EPA's effect?
Yeah, so you're right, because we still have not properly treated LDL cholesterol. Also, Japanese respond, again, they need a third, for the same dose of a statin, Japanese use a smaller dose because they get higher serum levels, so they're more sensitive to statins. But you're right, and that was published around 2007, I think. It's an older trial, so we learned a long way. One time we were afraid of getting LDL cholesterol too low, but so what we learned right now is that if I have high risk for vascular disease, getting LDL cholesterol less than 1.0 has been shown to cause some coronary regression on angiograms. So you're right. But it did show that through a totally different mechanism, not really accounted for by LDL cholesterol, that you can actually decrease cardiovascular events. So you're right. You want to treat both of those risk factors. So again, LDL is part of the LDL is part of the LDL pathway, and it's basically receptors on the liver. The liver is sort of the command center with the intestine, where lipoprotein lipase and triglyceride remnant particles are a different pathway causing remnant particles that can cause atherosclerosis. And also EPA has multiple properties. So you're right. So we didn't properly treat LDL cholesterol back then. You're absolutely right. But it did show reduction of cardiovascular events by about 20%. And just to show some of the differences, so EPA and DHA, this is courtesy of Rob Hegley. He's one of the smartest guys I know about lipids, and you can see that they're different. So at one time, I wasn't too concerned the difference between EPA and DHA. I'm very concerned right now because they can both lower triglycerides, but DHA can cause LDL cholesterol to go up, where EPA causes LDL cholesterol to go down, has more effects on the markers of inflammation, and it is really a very much an anti-atherosclerotic component. Next slide, please. Where DHA negates some of those effects. Doesn't mean that DHA is not important, but EPA is, the biology of EPA is that you want to get a purified pharmaceutical grade. It is a wonderful compound for lowering atherosclerosis. It comes from fish, the cool water fish. Next slide, please. And that's something it's important. And this is actually a neat slide here. So the brain really needs DHA, and the vasculature needs EPA for protection. So if you look at this slide at the top there, maybe your pointer, you can see when DHA penetrates the membranes, it penetrates the membranes differently in a different organizational fashion, where EPA slips into there, and those little blue molecules on the bottom were where DHA causes distortion of membranes is that EPA is an antiarrhythmic agent. It does actually decrease sudden deaths, and it is probably pro-atrial fibrillation, but more importantly, it decreases sudden death mortality, and that's important. Where DHA, again, good for the brain, or EPA is good for the heart and the blood vessels as well. Next slide, please. Really important. This is actually a complicated slide. This looks at all the benefits of EPA. So what we're going to show you a little bit later is that EPA can actually remove or help heal the plaque. It has multiple effects. And one of the mechanisms that I kind of like about EPA, you can see all these mechanisms listed above, it actually works in the plaque. It's actually a field soldier on the atherosclerotic plaque as an antioxidant, as different markers of inflammation. And unlike vitamins, vitamins do not work as antioxidants in the tissue itself. They work in the bloodstream. So if this part of EPA is the most important, that means that EPA will be good for every patient who has risk of atherosclerosis. Right now, we know on top of statin therapy, and predominantly the higher the triglycerides, the more the benefit. So we're learning a lot right now. So I really like this concept is that EPA gets into the plaque itself and has multiple properties, and one of them from decreasing inflammation, but it's also directly involved in atherosclerosis. Next slide, please. Now, EPA or IPA is not fish oil. Let me explain. Next slide, please. If you look at most commonly fish oil preparations on your left, you can see that they're a mixture, and that EPA or fish oils has a mixture. And here, the one preparation, 9% of DHA, 21% EPA, has a lot of saturated fats in it, other fats as well. Often goes rancid. So traditionally what happens is that you take the fish, you boil the fish, and you produce these nice fish oil capsules. Yes, get the impurities out of the fish oil, but you don't have oxidizable antioxidants effects of this right now. So one of the reasons that most DHA and EPA preparations aren't pharmaceutical grade is that they just don't work. They just they have a lot of contaminants, where you can see that pure IPE or has basically 96% of EPA pharmaceutical grade, and it has the properties. And it turns out that that the EPA is a protective effect, and maybe DHA is bad for the heart. We're going to learn a little bit more by the strength trial in about a month or two from now, so we'll have more discussion about that. But right now is that they're not the same and they're different. Next slide, please. So,
sure. And quick question while you're in the middle of this, from Reza, are any of these products, can they replace statins or fibrate for people who cannot tolerate statins? And what is the least myopathic statin out there available right now?
Okay. So I think they're totally complementary and different. So LDL cholesterol is a bad cholesterol, and what I want to get my LDL cholesterol less than 1.0 in very high risk patients. I also want my triglycerides less than 1.0 if I had my dream team. And if you Google statins and soreness, you get 1.3 million hits. It says what an awful drug. And what I learned from politicians and others is that there's so much bad information out there. So one of the things we put together are YouTube channels is to try to put some science behind this. So two of the largest trial called GOS3 alternative is when you get people that are statin intolerant and you give them fake pill or real pill, they can't tell them apart in the vast majority of the time. So one of the saddest parts, and today I saw a person that said she overdosed on Crestor, and she couldn't walk. She had to go to the emergency room. Her CK, ALT were normal. She said, "What a bad doctor I am." And within 2 days of stopping her statin, or going from 40 of Crestor to 10, she's feeling fine. Myopathy is a real entity. I've seen about 30 cases of rhabdomyolysis from statin therapy, and it's not subtle. Their CKs are 10 to 40,000. They go into renal failure. It's a rapidly progressive muscle weakness myopathy, and you can see it by biopsying muscles and you can see that. But soreness, aches, and pain, CK rise to 500 to 2,000 is just background noise. And if you actually look at people who complain of statin soreness, the vast majority are taking natural substances. They don't like doctors. They like natural substances. But I think saying that 20% of people who are sore is related to medication. If you actually replace the statin with a different soluble statin, you add coenzyme Q10, you can do wonders. So what I do with people who are statin intolerant, I give them statins 3 times a week, 5 to 10 milligrams, let's say, of Crestor, along with ezetimibe, coenzyme Q10 at 200 milligrams a day. And you'll see that over 70% of people who are sore on daily statins can take some degree of statin therapy. What I need to find out for every patient, and before I die, the trial that I'm going to do is that you're sore on your statin therapy. We're going to give you a real pill, fake pill, and cross you over twice. I'm going to find out for sure for that patient if they're statin intolerant. The problem is to getting placebos or putting statins into capsules. The project of 500 patients will cost around $90,000 to do. So it's something I'm going to do at some point in time. I'm going to try to find a way to do it less expensively. But I'd like to say to Mrs. Jones or Mr. Smith, is Dr. Kernew making you sore, or is life making you sore? And let's do this experiment in you, and we'll give you 4 boxes, 30 days of each real pill, fake pill in a blinded fashion. I will be blinded, the patient will be blinded, we'll measure all the safety parameters, and we'll find out for sure for you as an individual whether or not you're truly statin intolerant. And I suspect over 80% of the time, it's a belief system. You think the drugs are bad. And some people feel this, so, and we'll have to prove that. So it doesn't matter what I think or you think, it's more important what the patient thinks. So people historically have used things like pravastatin, fluvastatin, lovastatin, or small doses of statin therapy. So there is some data that vitamin D at 1,000 to 2,000 units a day, or coenzyme Q at 200 milligrams can alleviate some of the soreness you get on statin therapy. There's some data that statin therapy depresses coenzyme Q10 in certain patients. The data is not particularly strong, but certainly it's worth a shot in using that circumstance. So simple question, complicated answer, but the vast majority of people can take statin 3 times a week, Monday, Wednesday, and Friday, along with coenzyme Q10, and you pick and choose. Like I said, some days you can exercise and save the world. Some days you just wake up and you're sore. So people can adjust the dose. That seems to work quite well for the vast majority of people.
Excellent response, Dr. Kernew. Just a time check so everyone is okay. It's about 8 o'clock, and we're going to keep going further, but I hope everyone's enjoying. And again, feel free to ask questions in between.
So I went to Costco on Sunday with one of my friends, Chad. Chad's a guy that's a vegetarian. He loves vitamins, and we looked at the EPA preparation. So you can see this is that you can see different preparations of fish oil. So it looks like a beautiful capsule. And basically, you can see that this was the preparation that had the highest content of EPA I could find. It's not pharmaceutical grade. It does have DHA in it, and it really is not protective. So you can look at EPA or IP is that it's a clear, pure compound, or if you can look at combinations of supplements you get at the health food store, they're different. They're oxidized, they're impure, they have contaminants in them, all in there together. Next slide, please. And the reason that becomes important is now in Canada, you can see you can get this compound called Vasipa. It comes in capsules. You take 4 grams a day, and that was the dose tested, and decreases cardiovascular events by at least 25 to 30%. It's approved by Health Canada, and very important that EPA does not cause a rise in LDL cholesterol, where the fish oils that you do get are not pharmaceutical grade. They have contaminants, and depending on the preparations you get, you might have to take a lot more capsules. So we calculated some from Costco, you can take anywhere up to 40 capsules, but some of the capsules that we did find, you can actually take 10 a day if you want to get that 4,000 EPA dose. But the problem is that DHA may negate the benefit. So statins are important, But IPA, again, it improves endothelial function. It produces nitric oxide, it stabilizes membranes, it decreases inflammation. It really causes plaque stability. These are all in experimental data, and it's a good antioxidant as well at the tissue level. And statins have some of these effects, but statins basically lower LDL cholesterol, and that's what they're designed to do. They do lower CRP to some degree, but IPE has a lot more effects in multiple areas. And next slide, please. So they're totally different, and this goes back to one of the things is that managing triglycerides. Triglycerides are more amenable to lifestyle changes, and I'll let you cruise that video when you want to at this point in time. But basically, anything that's white sugar, white flour should be replaced with green vegetables. And in the keto diet, British Medical Journal in 2020 did a really nice review on keto diets, and I learned some interesting facts. It's not accepted by everybody, and the dietary literature is hard to look at, but basically, when you get rid of bread, carbohydrate, when you get rid of carbohydrates for many individuals, the craving goes away. From a personal perspective, it helped me lose the last 5 pounds. And so what I'm doing in different diets, we have this book, 30 Days to Healthier You. So to me, is really, and I think we have to try different diets at different times. So this is a diet that we're working right now. So I'm on my 4th week of this diet right now. We do have the sugar club, and we have things on cholesterol. And more importantly, we have a video on atherosclerosis, the progression of atherosclerosis. As you know, at the age of 30, 30 to 40% of us already have atherosclerosis in our bodies. So, and that's a normal person. So much to learn. And that one of the things that we've concentrated in the past was in, doing stress tests. And it's good to do stress tests to find out the severity of ischemia, but more importantly, it's better to protect and treat over longer periods of time. What it looks like to me that EPA works at the tissue level, and it may be good for all atherosclerotic plaque, but that needs to be studied further. I'll show you what we do know right now, and we're still learning. So it's a very exciting time to be involved in atherosclerosis protection. Next slide, please. Again, the Reduce It trial is a landmark trial. You heard a lot about this, and if not, I'll just review some of the key findings in this trial. Next slide, please. So the Reduce It population, next slide, please. So basically, just under 10,000 patients or 8,000 patients were randomized to pure IPE, which is a stable form of EPA, with great follow-up, complete data. So a McMaster approved randomized controlled trial, 1-to-1 randomization to basically EPA or IPE versus placebo, and followed over about just under 5 years, 4.9 years of follow-up. Next slide, please. And what's really remarkable is that they picked high-risk people, because triglycerides is a marker of risk. Again, the trial, they changed the criteria as the trial went on. So one of the big predictors of risk is vascular events. So if you had a vascular event, you're 3 times more likely to have another one, unfortunately, die from this. And diabetes is a marker for vascular disease as well. So if you have diabetes and the risk factors, so high-risk primary prevention, 70% of patients already had vascular disease, and 30% of patients were diabetics. Where the GILIS trial was the other way around, is that most of the patients were primary prevention trials. And again, you had to have a triglyceride between 1.5 to 5.3, and you had to have an LDL cholesterol that was well treated somewhere between 1 and 2.5 to get into the trial on good doses of statin therapy. Next slide, please. And it turns out that 99% of the patients were maintained on statin therapy. So the GILIS trial was mostly women. This trial, the other way around, mostly males. Again, the cohort, 70% of patients had vascular disease. 30% were high-risk primary prevention diabetes with another risk factor. The GILIS was the exact opposite, showing the same beneficial effects. Now, diabetes was prevalent, and when you look at triglyceride-rich populations, you'll see overweight triglyceride-rich patients. only 30% of patients were on the highest dose of statin therapy, and less than 10% of patients were on ezetimibe. So basically, my go-to combination with to get LDL cholesterol is the highest dose of statin. So that's Lipitor, 80 milligrams, or Crestor, 40 milligrams with 10 milligrams of ezetimibe. And my goal in very high-risk patients is to get patients to less than 1.0. So this business about, this number of 2, it needs to be changed. And you'll see a more aggressive approach, and we'll show what the Europeans have decided in a few minutes from now. Next slide, please. But again, the baseline triglycerides were about 2.4, HDL was 1, LDL was 1.91. So not ideal LDL cholesterol, but very well treated. And if you would have said to me, your LDL is less than 2, your triglycerides is 2.5, 5 years ago, I said, you're done. That's it. You don't need to do more. We also learned that if you get LDL to less than 1, you get another 20% reduction of cardiovascular events. Now that we have patients with high triglycerides, how do we get rid of more heart disease? Let's go to the next slide, please. And that's why the REDUCE-IT trials is such an exciting trial. They were well treated. Again, almost everybody was on statin therapy. They were well treated. This was the Cadillac of baseline medical therapy. Next slide, please. And here are the results. Look at that p-value, 0.000000001. Holy, you know what? The chance of that being by play of chance is, it's like getting hit by lightning 5 times. I mean, this is real. You show a reduction of cardiovascular events by 25%. They used a 5-point MACE. Basically, we'll come back to that in a sec, but basically, traditionally, 3-point MACE is basically stroke, heart disease, and fatal cardiovascular events. They expanded that to include unstable angina, revascularization, softer endpoints. So if you were just stopped at an LDL of 2, a triglyceride of 2 and change, 22% of patients would have had a vascular event over the next 5 years. You can get rid of 25% by treatment of pure EPA. Number need to treat here is 21, with an absolute benefit of almost 5% absolute benefit. Remarkable. Next slide, please. Very exciting. If you want to use the conventional 3-point MACE, you still have a reduction of cardiovascular events by about 25%, but the number needed to treat goes up to 28. That is a big chunk of heart disease, just over a period of 5 years. Next slide, please. With a very significant p-value. And it didn't matter if you had diabetes or no diabetes. Next slide, please. It didn't matter if your triglycerides were above 2.2 or less than 2.2. Again, or even lower than that. But basically, it wasn't a trial of very low triglycerides, but it showed that triglycerides didn't seem to correlate to the benefit. Next slide, please. I would have thought they showed more benefit effects over time. So if you look at the endpoints, the primary endpoint, reduction 25%, secondary endpoints, everything is in the right direction. And all-cause mortality is in the right direction. Cardiovascular deaths is a p-value that's significant. The only p-value that's not significant is total mortality, but a very strong trend of 13%. So this is real. It's not this is the second trial to show this with IPE or EPA, depending, again, pharmaceutical grade. This is not the fish oil capsules you buy at the drugstore or you get at Shoppers Drug Mart, you get at Costco. This is pharmaceutical grade IPE that's been well researched, that has multiple properties that we listed. Next slide, please. And it shows in the primary and the second endpoints, and it didn't really matter if your triglycerides were low or high. So everybody got treated with statins. It was just predominantly in a high triglyceride. So high triglyceride is a marker for increased vascular risk. Next slide, please. And it showed that the triglycerides were lowered by about 20%, non-HDL by 13%, LDL by 6%. Remember, DHA causes LDL to go up, where EPA lowers LDL cholesterol, and HDL went in the wrong direction by about 6% or so. So again, next slide, please. So triglycerides, LDL were lowered. ApoB, which is a marker of all remnant particles. C-reactive protein was lowered by about 40%. EPA levels went up by about 400% or so. And this level of EPA correlates to the same level that you got in Gillis that used half the dose roughly. But again, the Japanese consume 5 times the fish consumption compared to North Americans. So it showed that on top of therapy, you had a remarkable beneficial effects. And it turns out the number one predictor of benefit, I would have thought it would be triglycerides or CRP, but it turns out it's high EPA levels. And EPA is also working in the blood vessel itself. It works as an anti-atherosclerotic medication. So if that's a predominant benefit, then the benefit would not be related to the triglyceride lowering. Now, I believe that triglyceride remnant particles, high triglycerides, low HDL fibrates are a good thing. That's a disputable area, and we'll learn more about this. I thought that DHA might be a good thing too as well, but we've actually shown you just the opposite, and the strength trial will tell us a little bit more in a month or two, but remarkable benefit at this point in time. And that's another 25% of heart disease over a period of 5 years. Next slide, please.
Sure. And sorry, Dr. Curlew, I think we're just seeing your mask. If you could raise your camera just a little bit. Just a little bit. Then we'll see your face a little bit more.
How do I get my face in?
Sorry, we're just seeing your mask.
Sure.
Now we can see.
You see me there? Sorry, I'll get this over here. Sorry about that.
That's okay. I'll advance here.
So you can see my slim body right now. And so what I'm going to do is I'm going to lower my CRP tonight by playing tennis or doing some stairs. So as we say, that atherosclerosis is fought on many fronts. So we have everything from weight reduction to atherosclerosis, even to meditation and relaxation. So take a peek at that when you get a chance. I'm really proud of the team that put this together. There's a lot of facts in there. And there's just so much to say about atherosclerosis. Next slide, please. So what is the price to pay about adverse effects? Let's look at this. So basically, one of the effects of IPE is that it does actually increase bleeding, gastrointestinal bleeding a little bit. So they're all basically small bleeds. There's no big time hemorrhagic stroke, or in fact, it decreases overall stroke, but it does cause a little bit of bleeding. Next slide, please. And it does cause atrial fibrillation, and a little bit more anemia. So the reason that there is diarrhea is that the placebo is basically mineral oil, and mineral oil is used for centuries to treat constipation. And so you have an anti-constipation effect, and you get a little bit of loose stools from the mineral oil. So basically the only downside of EP or IPE is more atrial fibrillation, a small amount, and those were predominantly patients who had atrial fibrillation. Overall stroke is decreased, and a little bit more bleeding. And next slide, please. And so again, is that reduce it shows a clear benefit from cardiovascular events to stroke reduction to heart attacks, revascularization, and hospitalizations for unstable angina. So you can see that 1 in 6 patients will have a cardiovascular event if you just leave the LDL cholesterol around 2, and if you keep the triglyceride around that level as well. Next slide, please. And again, the price to pay is just atrial fibrillation. And you can see these benefits. These p-values are so significant, and it's so big, it's so real, so exciting at this point in time. We can still debate the actual mechanisms. There's probably multiple mechanisms, but I think the most likely one that affects the plaque itself and the tissue level itself, as well as lowering remnant particles, as well as lowering C-reactive protein, and also it probably decreases sudden death by just arrhythmic properties on the membrane itself. So multiple benefits here, clear reduction, clear benefit. Next slide, please. And this just illustrates this, and how you slice it or dice it, it's real. Next slide, please. And it's the second big trial to show about this. So what about revascularizations? One more slide. We won't go through this very quickly. Again, look at that p-value, 0, 0, 0, lots of zeros. I can't even count those zeros. And revascularizations are lowered by about 35%. So wow, really big number need to treat of 24 here. Next slide, please. Now, one of the things is that some of the benefits. So the Evaporate trial is basically a sister trial of about 80 patients or so. Next slide, please. That looks at the effect of IPE or EPA formulation, the same entrance criteria as Reduce It. So, and it showed that what happens to the composition of the plaque, what happens to the plaque itself, and they use CAT scan technology to look at this. So with Repatha, they used IVUS technology, ultrasound, this used CT-guided therapy to look at this. And if you get LDL to less than 1, you can actually promote atherosclerosis regression. Let's look at what happens when you give for 18 months worthwhile of IPE. You can see that the baseline and the plaques by CT, the natural thing is that they want to progress, and high triglycerides is a marker for increased progression. Next slide, please. There's different compositions of plaque in this. And basically, low attenuation plaque is a vulnerable plaque. So you can see on the placebo group where LDL cholesterol is probably hovering between 1.5 and 2. There was progression of atherosclerosis, and it's more the vulnerable plaques. Those that have thin, fibrous plaques, lots of inflammation, lots of white cells in there. And you can see that giving IPE decreases or causes regression. There's different ways of looking at plaque, from calcification to total plaque volume. One of the things that people are looking at CAT scans for CT. It's well popularized in the States. It's something we don't do very much in Canada. I would rather just treat you. So instead of measuring plaque, why don't we just prevent it from happening? And this shows clear reduction in plaque volume composition and mostly the vulnerable plaque with these trials. This shows you the percentages, the same thing again. So I won't belabor this point. The most important thing is these low attenuation plaques, and this is just a technology to look at this. This is, done by CT imaging by experts in the field. Next slide, please. So this actually reminds us is that it's important to make the plaque look better, but more importantly is to decrease cardiovascular events. And this is actually a reduction of cardiovascular events, again, by 34%. This is a huge benefit over a period of about 5 years. Next slide, please. So the plaque is better, but more importantly, the patient is better. So again, Reduce It, Vasipa is 4 grams of this magical EPA or IPE, or how you want to pronounce it. It makes the vulnerable plaques better and translates to reduction of cardiovascular events. So the early effect was at 9 months, and they showed the 18 months at the European Cardiology meeting. So we have so-called the marriage of clinical events with imaging of the plaque to show that the plaques actually get better. So that's kind of nice to see both levels of data. Next slide, please. So very exciting. Again, this shows clear benefit to IPE or Vasipa. It lowers the plaque volume, the vulnerable plaques, and lowers cardiovascular events by at least 25% over a period of 5 years. And this was predominantly done in a triglyceride-rich population, but again, the triglycerides did not correlate to benefit. We have so much to learn at this point in time. The price to pay is minor bleeding, a little bit more atrial fibrillation. Triglycerides is a marker for increased risk. It may be related to vulnerable plaques as well. So much to say about this. There's so many slides that I want to show you. I never have enough time to share these with you. And we'll come back to the next slide, please. So this is real, it's phenomenal. It's the second major trial to show this. Next slide, please. And it's the level of EPA in the bloodstream. It's important. This is endorsed by multiple organizations. The Canadian guidelines will come out in the next month or two, and they'll endorse this too as well. So it's an international benefit. Everybody looks at this. My favorite guidelines are still the ESC, because I think they're the most advanced guidelines, but and we'll see what Canada has to say. Next slide, please. And this actually shows you can take a scoring system. And so when we said at one time, we let LDL cholesterol drift up to the 4 to 5 range. And we can say that, very high risk patients by any scoring system or people with vascular disease, you should get LDL cholesterol to at least less than 1.4, depending, and you can go somewhere between 3 to 1.4. Next slide, please. And they also identify a level of risk where you have more than one cardiovascular event over that last year or two. and shows that getting LDL cholesterol to less than 1. So basically, in patients who have vascular disease in more than one territory, you have peripheral vascular disease, you have carotid disease, you have coronary artery disease, you're in big trouble. If you have more than one cardiovascular event, especially at a younger age, getting LDL cholesterol to less than 1. We have basically over 100 patients whose LDL cholesterol is undetectable. They don't get any adverse effects. They just live longer. We've also shown you very clear and concisely that lowering remnant particles, lowering CRP, stabilizing plaque with IPE is vascular protective. It lowers risk by 25% without a shadow of a doubt. The only shadow is that is DHA good or bad? It looks like DHA is good for the brain. It doesn't look like it's good for the heart. We're going to learn more about this, but we have IPE or pure EPA, pharmaceutical grade, not the stuff that you can buy in the supermarkets. This stuff works. It's very vascular protective as well. So they're totally two different separate pathways. And the one that I would like the most, it works as an antioxidant, works as an anti-atherosclerotic at the tissue level. Only time will tell the exact mechanism. These trials can't really tell you that for sure, but they show clear benefit. Look at all those zeros. Next slide, please.
Sure, and just a very practical question, and I know you'll give a very honest answer. So Dr. Kernew from Joanna, would you put patients with CAD and proximal AFib who are on NOAC on IPE?
Yeah. So the answer is yes. The reason for that is NOACs decrease the risk of bleeds by 70%. Unless you're at a very high bleeding risk, you get a slight increased risk of bleeds. What I would make sure that you're not taking aspirin if you're on a NOAC, because NOACs and aspirin increase risk of bleeds by 40 to 50%. And you have a little bit more atrial fibrillation. But you decrease stroke and overall benefits. So again, having atrial fibrillation doubles your mortality, and part of that mortality is related to cardiovascular events. So the answer, I don't really have a problem with that. The only caveat is risk of bleeding, and the increased risk of bleeding is minor bleeding, so I'm not particularly worried about that. And again, as we learned, this is actually from a slide from the European cardiology meeting. So you can be on a low dose of a statin and decrease LDL by 30%. You can be on a high dose of a statin, lower LDL by 50%. You can add ezetimibe and lower LDL cholesterol by 65%. And the combination of high dose statins and 10 milligrams of ezetimibe lowers vascular events by the order of about 60% or so. PCSK9s are a wonderful group of medications, but they're just very expensive. Remember, statins and ezetimibe are less than 25 cents a day, where PCSK9s are retailed for $7,000 a day, sorry, $7,000 a year, excuse me. They're great drugs, but they're, as the Wall Street Journal says, it's a super drug nobody uses because of cost, but and so if I have my heart attack tomorrow, I'm in for an LDL cholesterol less than zero, close to zero as I possibly can. And patients who have more than one vascular event, disease in multiple territories, especially at a younger age, I think it's very reasonable. You're not doing any disservice by getting LDL cholesterol as low as you possibly can. But we also have a second pathway that lowers vascular events by 25%. Next slide, please. And we know that high triglycerides are a marker of risk. And then what we didn't show you is that high triglycerides are also have remnant particles. These are something called chylomicrons, VLDL remnants that are rich in triglycerides, what I believe cause atherosclerosis. And we'll see what the fibrate story shows in those patients as time goes on. So a lot of patients have high triglycerides as a marker for increased risk. And whether or not it should be your target, that's something that we're going to learn more about. But the CEPA shows clear reduction of cardiovascular events in that population. There are multiple potential mechanisms. Next slide, please. And so when we come back to our patient, so we have a 67-year-old female with an LDL of 1.3. I would actually give her 80 milligrams of atorvastatin and 10 milligrams of ezetimibe. I've only increased the cost of about 25 cents in her therapy, and I will get LDL cholesterol to around 0.5 in that circumstance. I will also pray and work with her for exercise and to not smoke, and she meets the entrance criteria for reduce it. If cost is not a factor, then I would give her Vascepa at 4 grams a day, or encourage good lifestyle changes. And I would shoot her if she had another cigarette. No, I can't do that. But basically, you can get an additional 25% reduction of cardiovascular events. Remember, having good relationships is important too as well. So try to encourage that nurturing. So what I hope I can convey to all of you is that I will do anything I can to help you treat patients. Next slide, please. And we need to learn how to work together. For this 52-year-old gentleman who's had diabetes since the age of 45, I worry about his long-term risk. His 10-year Framingham risk will be relatively good. And so you can pat yourselves on the back saying my Framingham score is good, my LDL cholesterol is close to 2, my triglycerides are elevated. He's on the newest data, SGLT2 receptor antagonist. I would give him 40 milligrams of rosuvastatin, 10 milligrams of ezetimibe, and if cost wasn't a factor and had good insurance, I would give him Vascepa at 4 grams a day. And again, really work with him with all the lifestyle changes, because his long-term risk, unfortunately, is very high, and he meets the entrance criteria of reduce it. Remember, reduce it has diabetes, prime prevention, additional risk factor. He has hypertension, for instance, an additional risk factor. So, and there's very few diabetics that don't have another additional risk factor. Next slide, please. And so the drug is approved in Canada. It works. It's approved for vascular disease with high triglycerides predominantly at this point in time, but certainly I think it works in all domains. It's been tested on top of statin therapy. Can you treat without statins? Probably, but I wouldn't. It's like sort of the Toronto Raptors. You need, you can't have one superstar. You need multiple superstars. So we have statins as a superstar. We have Vascepa as a very strong player. Sort of, it's like Carl Lowry to me. He does a lot of things extremely well, puts his best effort, and that's Vascepa to me. It's a good drug in this situation. So I would also use ezetimibe too, and I would really work hard at lifestyle changes. We do the stairs, we do CN tower climb when that permits. We have life events. Please join us and keep work hard on this. Next slide, please. Again, is that triglyceride is a marker of risk and may be a future target of therapy with fibrate therapy. We'll have to see what the more recent data comes out. So I use fibrates to prevent pancreatitis when your triglycerides are about 10. We know that mixtures of EPA and DHA that are not pharmaceutical grade don't work. And we know that probably pharmaceutical grade DHA and EPA probably don't work as well. We'll have a lot to work with, but we know that IPE, as Vascepa in the Reduce It trial, works, reduces cardiovascular events by 25%. We know that pure EPA many years ago works as well. So EPA, EPE, or IPE, pharmaceutical grade works. And it works best in people with vascular disease. It works in all groups of people, probably, but we have the most evidence in vascular disease and those with the borderline high triglycerides, 1.5 or greater. It will probably work across the board, but I can't say that well. We know that from the Gillis trial, it did work with lower triglycerides, but it worked better with higher triglycerides as well. Next slide, please. So lots of data, very important data. What you have here is my office card. It has our fax number. You also have my cell phone number. So I certainly do not mind being interrupted. You guys are very quiet. You don't ask enough questions. I have 5,000 questions, and I have 5,000 more things to show you about vascular disease. As we start with is the Harvard says longitudinal study shows that quality relationship. If I can make your life a little bit easier, I will do so. You have my cell number. You can call me, text me. You have our office number. I have a nice little bubble in our place here. We have a beautiful office. We do our own cardiovascular testing. We really promote prevention. 30 Days to a Healthier You is a book I'm very proud with the team and stewards here at my side and others as well. I can just see so many of our team. I'm very proud of what we accomplished. And if all goes well, I'll retire in another 39 years from now. I wish you all well. I know that's a lot of information, and you'll only remember about 10 to 15%. So that's why we recorded. That's why I can talk so fast. You can slow the speed, you can double the speed, but realizes that the heart disease is a big problem, and that there's so much to say. You took out all my joke slides, which is probably a good thing. Um, and uh, and I think I'll pause for a second, open to some questions. Any thoughts from people? And what I'll ask is, Phil, for those who want, if you want to do a 30-day health challenge, we'll be glad to give you one of our books. But I want you to commit yourself to trying to be healthier and make your patients healthier. And if I can help in any small way, be very happy to. Um, I think I'll pause. Any thoughts or questions?
Yes, thank you very much for that very informative presentation, Dr. Chernew. We do have a couple of questions, and again, before we get to them, please also unmute yourself. Let's make a good dialogue and discussion and keep it very open. So there's one again from Joanna, and asking, what if the above patient that we had before had a triglyceride that was actually less than 1.9, or let's say less than what was in the study, which is less than 1.6, let's say? What would you do then
Yeah.
to this patient?
So the answer is the data is the data. So if you're a pure trialist, you say no. But to be honest with you, is that I th- I think of this drug working more in people that have metabolic syndrome. So again, triglycerides, overweight, not exercising, eating a bad diet. So for instance, this week I had this patient that won't exercise, won't stop smoking, which is a far too common situation, who's met at the world and has no good relationships, as I can see. And so it was a very easy decision. Now, his triglycerides are around 2, so it was a very easy decision to go on Visipa. He had some private insurance. And the company right now has a program for that, and they can tell you about that later. Um, Also another patient this week who had a very high triglyceride and can't afford any medications, has no coverage. The only medication he's taking is just insulin. So unfortunately, he would not be a candidate to take Visipa because he can't get it at this point in time without the government doesn't pay for it at this stage of the game. We'll see what happens over time. So the strict answer is that it's the overweight patient. It's the patient that has the highest triglycerides, low HDL, that derives the most benefit. I do believe it probably works outside of that, but I don't really have enough data to say that. So you're going to have to extrapolate for yourself. I don't think it's unreasonable either way to say yes or no. So if you're pure trials, the answer is no, but you can go back to Gillis, saying that those patients with low triglycerides also benefit too as well. So I think we're stuck. And I presented multiple mechanisms of action. If the mechanism is, we know it's related to high EPA levels in the blood, and if EPA is working at all in the vessel wall, then it doesn't matter what the triglyceride level is. But if it's working through remnant particles, the way we can't identify yet, or it's related to inflammation, then that's important to know that as well. So I feel a little stuck there. So I'm sort of feel like a little bit of a politician here. I'm dodging a little bit because I don't know what to say. I would certainly treat their LDL cholesterol. That's a more mature science. But this science is very positive as well. And that's just outside the boundaries. So I feel stuck. So maybe on a Monday I'll treat, on a Tuesday I won't. I just don't know what to tell you for sure right now. And maybe I'll know a little bit more after the European or the American Heart Association meeting. So I'd love to get back to you in about 2 months from now, and we'll have more data too as well.
And another follow-up question. Would you agree that all diabetics should be on statin and ezetimibe regardless of their lipid levels?
Sure.
Or are there any exceptions to this?
Yeah. So if it's a person you don't want, we determine therapies with patients. So if I can get the LDL cholesterol to less than 1, then I'm happy. And for some people, that will be on a low dose of a statin or no statin therapy. For the vast majority, you will need to be on a high dose statin and probably ezetimibe to get the LDL cholesterol to around 0.5 or so. The reason I feel easy about statins and ezetimibe, it works. We have good data. What I didn't share with you is that there's a second randomized controlled trial with ezetimibe done in Japan again. It took individuals over the age of 75 years of age in primary prevention, and they gave ezetimibe without statin therapy. And it showed a reduction in older people of 25% reduction in cardiovascular events. In the Improve It trial, 40% of patients stopped therapy. Ezetimibe lowers LDL cholesterol between 8 and 25%, on average of about 15%. So it works. It's not a strong agent. It works through blocking absorption of cholesterol in the intestine through a specific protein molecule. So if my LDL is less than 1, I'm happy. And I'm happier with 0.5. In very high-risk patients, lower is always better. So that's why I look at the LDL cholesterol. And again, the angiographic trials with LDL cholesterol show angiographic regression of LDL less than 1 more consistently. But I also know that LDL cholesterol is not the whole equation, because you can have an LDL cholesterol 0 and still have atherosclerosis or LDL. So it's there's still a lot of events beyond LDL cholesterol as well. So I hope that helps a bit.
Thank you for that. And again, any other questions, please feel free to unmute yourself or write in the text box. But apart from that, this is your chance to ask the expert. So anything you have related to this talk or anything related to cardiology that you need to get clarified, please ask Dr. Kernew. Otherwise, he's going to run away and play tennis. So we want to make sure we have him.
No rush, no rush. I still have a few more patients to.
Yeah. Oh, we have a question here by video.
Hi, I'm Reza. How are you?
Good. How you doing?
Good. Thank you. Thank you very much for the presentation. It was great. There are lots of new things that we usually don't see in a book or in other articles. So that was new and interesting. So what products are in the market that we can add on what other medication that we usually prescribe? Is it prescription? Is it over the counter? And what brand products? So we're not.
So the only form of fish oils that you can prescribe that are a benefit right now in Canada is Vasipa. It's by prescription. It's 4 grams a day. The fish oil preparations that you have currently available are not cardiovascular protective. We have good studies to show that they don't help. Other products that are coming right now is that colchicine, for instance. Colchicine in randomized controlled trials show reduction of cardiovascular events, probably by decreasing inflammation at this stage. LP(a) is a different molecule that is really not lowered by these compounds to any major degree. There's now monoclonal antibodies that are being targeted against that pathway. They're in clinical trials at this stage. One of the things, if you can help people with getting better relationships, just exercising, for every 1 MET in activity, vascular events fall by 10%. That's based on observational data. I don't know about you, is that this COVID-19 crisis has caused people to gain weight. It caused me to lose weight. The reason for that is that inflammation, overweight, that central big tummy, makes your immune system not work as well, and it compresses your lungs. So what we do know, the overall mortality from COVID looks like it's 1%, but the young people that tend to die are overweight individuals. So being fit, losing weight, playing bad tennis. Look, I just did a mini triathlon with 25 people. I finished second to last. I got passed by 13, 14-year-olds, but at least I swam, I ran, and I bicycled. And I'm grateful to be able to exercise my mental health. And so all these sorts of things are important. And people that are just isolating themselves and getting worried, and I understand that, but you know what? Do something and encourage it. I think it's important right now, and lowering weight. So the drugs work extremely well, but the diet and lifestyle changes are so important, and it's more important than ever before. And this weight business, is that I just worry about people's weight right now. And I'm really impressed that losing 20 pounds plus can put diabetes into remission for 2 to 5 years in individuals as well. So I can't express that enough. And what I can get angry, and I get angry too easily sometimes, is that I don't care if you're successful. I do care if you don't try. So I'm going to do my darndest to help in any way. And I want to form a community with you guys. I want to be available, and I want to have more of these types of meetings on a regular basis and share things. One thing I will say to people is that statin soreness may not be a real disease for 80% of people. And what we often say is, oh, we're going to stop the statin. It's like, it's treating when Wayne Gretzky got traded away from Canada to the States, Edmonton has never made it back so far. And so don't trade away a statin unless you absolutely have to do so.
I gave fluvastatin and I think levovastatin to a couple of patients that never be able to tolerate, and they came back and they were quite happy. So keeping them with these, with least, also is not as effective as the others, the newer one, but at least patient can take, so they are happy.
Sure. So what I tend to use is Crestor Monday, Wednesday, and Friday. It's a low dose, like 10 or 20 milligrams, and every second day at coenzyme Q10. So basically, and I changed from a water soluble to lipid soluble. I said, you're taking Lipitor, which is lipid soluble. I'm giving you a water soluble vitamin, which is Crestor, Rovastatin. It doesn't penetrate muscles to the same degree. You take coenzyme Q10, this will help you 70% of the time. So Trump has made a career of telling people certain things. So, reality is reality, but we have good science. And there's two parts of the brain. There's the emotional part, and there's the science part. So you have to decide what you're going to use, and use both as best you can. It's so important right now, and we can do a better job about that. So I appreciate so don't give up on statins. But also, now we have a therapy that's proven in 2 large randomized trials. And what I didn't show you is all the biochemistry behind it. And I'm still learning. I have to thank Manish and his team I really enjoyed our conversations, and we're still going to try to figure out mechanisms, and there's so much to learn right now, but this is so exciting. P-value is so big.
Product are in the market that if you want to advise a patient to take for this EPA, IPE, so fish oil, there are so many things. So should we send the patient as an over-the-counter, or as I said?
So unfortunately, the over-counter preparations don't work at this stage. I'm quite intrigued about fish consumption. There's variable results from that. So I'm eating a very high fish. I eat lots of salmon, lots of mackerel, lots of tuna, lots of sardines, and I believe that's important as well. But EPA, the only one that shows science right now is pure EPA, the SEPA at this point in time. The rest don't.
What's the name of that? I didn't take it.
Say that again. I'm sorry.
What's the name of this product that you say?
The SEPA. So Philip's going to come bring you a book over and tell you about this over here. So it's let me see if I hear it. Hold on for a sec.
Dr. Carpillo, we'll get to your question. I see your hand is raised.
I'm trying to find my where it is over here. I'll get to that. And I'll go find some in a sec. I'll show you what it looks like.
Thank you.
There is.
Go ahead.
There is a question, and unmuted. Craig Carpillo, sorry for mispronouncing if I did.
That's fine. Finnish names get mispronounced all the time.
Well, my favorite hockey player is Solani, so I'm sure Greg Kernu, you know who he is as well.
The question is basically, what about plant-based materials for lowering some of the lipids, such as avocado oil and various others?
Yeah, so great question. And one of the things is that, so basically the omega-3 alpha linolenic acid, plant-based, and that comes from flax and from canola. way back when, the Untitled interim trial showed that you can decrease cardiovascular events in a small series. Can you find me some of the sleeper around somewhere? Around the box over here somewhere. Maybe it'll be here too as well. It showed a protective effect. There was a second trial of about 4,000 patients that showed a trend to benefit, but not a clear benefit with a vegetable form. Remember that ALA, vegetable form of omega-3, has only a weak conversion of maybe less than 2 to 5% to EPA and DHA, but it may have some protective effects. There was a trial done in Spain where people were randomized to extra virgin olive oil, 10,000 patients, or to basically walnuts, hazelnuts, or almonds, and it showed a reduction of cardiovascular events, basically non-fatal. So there is some weaker data right now, and what I'm learning right now is I'm more eating the fruits and vegetables than I am of too many supplements right now, because there's a lot of good marketing, but not enough good science right now. So the science for what you're saying is not as strong as we'd like, but there's some hints right now. So I'm eating a lot of walnuts. I'm eating a lot of almonds, and I think that's lots of flax. And I'm trying to avoid oils, because oils by themselves are rich in calories, and I'm just always eating too much. So there's some data extra virgin olive oil so we don't have a strong data set, and diet's hard to analyze because there's so many variables, and compliance with diet is often so poor. So a long answer is that so hazelnuts, walnuts, almonds, extra virgin olive oil shows something there in that circumstance, and you can add some flax to that too as well. Those are the oils that show the benefit at this stage.
And basically, if the patient were getting those oils from the food itself, eating avocados or eating greens, fruits, whatever, and the nuts, they probably are getting their protein too.
Yeah, so to me, one of the things is that about 3 years ago, I started a bet. We bet $500 to the charity of your choice if someone said I couldn't be a vegetarian. So I became a vegetarian a few years ago, except for fish. And on Thanksgiving, I'll have turkey. But basically, I become predominantly a plant-based eater. Number one, it's good for the animals. Number two, it's good for the planet. And the best source of protein at this point in time for everybody is in beans. And so the only problem with the beans is the gas production can be a problem sometimes. So, but saying that is that I feel really good about that. The only thing is I haven't been friendly to fish. I eat a lot of fish, so I'm a hypocrite when it comes to that point in time, and because I think fish is of value to you. This is what Vasipa looks like over here. I'm gonna show you what some of these capsules look like. These are 1 gram capsules each at this point in time. They go down nicely. They don't taste badly either. I could swallow. I need to get some water somewhere, but can you just find some water? You don't really have a bad taste to them. So, so by taking this for the next 5 years, I will lower my risk of vascular events by about 25%. And the only thing I'm using is a plastic bottle, which I don't like to do. And there we go. So, so to me, I chewed the capsules. I didn't really do a good job at crushing. I should have just swallowed them. So I think we have just so much to learn and so much to do better at this point in time. So I hope that answers your question a little bit.
Yes, thank you. I agree with a number of the things you're saying there. I cringe at the fact that this med increases atrial fib, because we see a much greater incidence in atrial fib in our baby boomer
Yeah.
population.
So what's happened to atrial fibrillation is that so the trial showed that in patients who have intermittent atrial fibrillation, it increased it slightly. So it really didn't cause a whole lot of new cases of atrial fibrillation, those are existing right now. So we now have pretty good data that if you have atrial fibrillation, losing 20 pounds is of huge importance, and no alcohol
That's right.
will lower your risk of future atrial fibrillation by 20%. You can over-exercise in some of the, the triathlons. So I'm a fake triathloner. I just do these mini triathlons. That means I can finish last anywhere. So I'm a bad tennis player. And if you know my hockey skills, I make everybody look good, especially the other team, because I pass the puck to the wrong players. But I really enjoy all the sports and things of that nature. Is that atrial fibrillation become a bigger problem, but the biggest problem we face in North America is diabetes and obesity. It's actually tripled since I started practicing, and so we have to do something about that. So that's why I hope that book helps a little bit, and our webinars and our get-togethers and working together. And I say this with all sincerity: if I can help in any way, I think it's important to make sure it's safe for people to exercise, and I think it's important to give people good information. So that's the best we can do it. And so I share your concerns about atrial fibrillation, but that's not a reason to not use Vasipa for most of the time. But I hear your point. I'm not concerned about that. I just worry about. So I really work hard those 20 pounds. And if I can do it, you can do it. So can the patients, and we can do it together. One of the things we started, we have something called the Weight Loss Club. They meet on Zoom once a week, and we have our health coaches that will love you, beat you, do whatever it takes to help you lose weight if that's what you need. And I got the support of so many people to help me keep my weight down, from my wife, my family, all my students, and so it takes the whole community to be healthy, and we need to work together in some way.
Well, thank you. Appreciate your answers.
Yes, thank you so much, Dr. Kearney, for being so honest and vulnerable too, and letting us into a little bit of your life and your passions. Again, we still have a lot of people on, so thank you for staying on. If you have any questions, again, this is your opportunity to ask the expert, and if you want to see him take Vasipa or any other drugs that you have questions about, please ask away, because he's here for you, and this is something very important and dear to his heart. And again, I thank you for everyone's time. Any other questions, comments? There was a question, Dr. Kernu, more related to the slides, and if you're posting this on a YouTube channel, like how can people access this again? Is that something that you would like them to have, a PDF version?
If everybody likes, we'll get you all the slides, make a PDF. You've recorded this event, so what we'll do, if you'd like, is that we'll post this on our website, or not a website, we'll post it on our YouTube channel. Right now, our website is broken. We have some fatal error we can't fix right now. So I love computers, but I'm not as good as I want to be. So we're working to fix that problem. But our YouTube channel is something that's working right now, and so. We'll post that on our YouTube channel, and I'll get Philip and others as team as well to get copies of that. So anything that I have shared today, be glad to give you all that information and share that with you. Does anybody want to take a 30 days to healthy you challenge with us and see if you can be healthier than me for the next 30 days? We can wait till after Thanksgiving.
That's probably the best time, right before Christmas. So without further ado, it is the 9 o'clock mark, so 2 hours. Very, very informative. I want to thank you again, Dr. Curnew especially, and obviously everyone who has attended this. Please get in touch with Philip as well. I think he left his phone number and email, and those that deal with Graham as well. Please get in touch with them. I'm the medical science liaison that can help answer any other questions if Dr. Curnew doesn't pick up his phone because he gave his cell phone number, but I'm there as well. So please reach out to any one of us. And again, thank you very much for joining, and thank you, Dr. Curnew. A very special thank you from us.
Well, thank you for the opportunity. And what I'll say is that I'd like to get together any time that people want to in a different format. There's so much to learn and so much to share. And there's so much that is changing right now. And I'm curious to see what's going to happen at the American Heart Meeting. The European Cardiology Meeting just came out. We're always advancing, but you know, people say you need 2 large randomized controlled trials. We have 2 large randomized controlled trials that show that EPA, pure pharmaceutical grade, decreases cardiovascular events the order of 25%. It works. The downside is, you mentioned bleeding and atrial fibrillation. The cost factor is something that needs to be considered. But you know, we have such effective therapy, and if we just stop at an LDL cholesterol of 2, we ignore so much more cardiovascular events. So from going from 2 down to 1, you decrease cardiovascular events by additional 20% or so. By treatment of remnant particles, high triglycerides with EPA, you decrease cardiovascular events by 25%. And the mechanisms are multiple, from inflammation to triglycerides. And more importantly, it looks like the effect is directly on the vessel wall, totally independent of triglycerides, and possibly totally independent of a C-reactive protein. I can't say that with confidence because this drug does a lot of things well, and what's the exact mechanism we're still learning, but it works. And I want to thank everybody for their participation. I've known Phil for a long time, and Nisha, we have lots of questions to explore. And the drug is available in Canada, so it's been available. When did it become to Canada? When was the drug launched in Canada? Now it's
end of February, around the 25th or so, February, or 22nd, I should say. So it's been available in Canada, and it's something that you can get at any pharmacy with a prescription. So it is, like we said, a prescription drug. It's not over the counter. You will need a prescription.
And the problem is trying to launch a drug during a pandemic. It gets drowned out. But this is where we are, and this is where we're going. And one question to remember is that this does decrease inflammation, and so the question, what does it do to COVID, is a great question. The answer is, well, nobody knows. The trials have looked at things like pneumonias, infections, and things of that nature. There's no higher incidence of this. Colchicine is now being tested in COVID, but COVID in the non-COVID patients with acute coronary syndromes, it does decrease. So colchicine low dose, 0.6 milligrams, 0.5 milligrams, does decrease cardiovascular events by 25%. Mortality does go in the wrong direction, where mortality goes in the right direction with this preparation. So we still have so much to learn, and an exciting time. So I want to just say the drug works. It's effective. It has multiple mechanisms of action. The most important, we'll still learn. It correlates to high levels in the bloodstream. And so there's where we are today, and we'll have a lot more to say as time goes on. So I feel really privileged to be around for 30-something years, and I have another 40 years to go if all goes well. So, but it doesn't stop us from learning, and it's an exciting time. So I want to thank everybody for coming out tonight, and I want to thank the crew here for putting this all together. You can only do you're only as good as the people around you, and thank you so much, Manish and others, and Philip, for all your support. So thank you so much, everybody, and if I can help, you have my number, and we'll talk to you later, and have a great night, everybody.
Thank you very much. And this will conclude our event tonight, and we'll see you on the next one. So thank you again. Take care.
Bye-bye now.